Hi, my name is Boris Chomet. I'm a psychiatrist in Paris in Sainte-Anne Hospital. I'm very pleased to present today how genetics can help diagnosis and treatment in psychiatric condition. So this talk is about genetics and psychiatry, and is part of the ENGAGE symposium. ENGAGE is a European network funded by the COST Action, supported by the EU. And the objective of ENGAGE is to enhance psychiatric genetic testing and counseling and training in Europe. So these are my slides of the disclosure. So when we start, the question of irritability is of big interest in psychiatry because we know that psychiatric disorders are highly heritable. There is a very common disorders, but the heritability of the disorders are more higher than for cardiovascular disorders, for instance. And based on twin family study, we know that, for instance, irritability of schizophrenia is around 80%, and the same for autism spectrum disorders. But many disorders, many psychiatric disorders are highly irritable, as you can see in this review. If we focus on schizophrenia, the heritability is high, and if two monozygotic twins share 100% of the DNA, if one twin is affected by schizophrenia, the second twin has a risk of 50% to be also affected. So genetics is really important in these disorders. But you can also see that when the twins share 100% of the DNA, they don't share 100% of the risk. So it means that environmental factors play a role in these disorders too. And you can also see from this graph that the irritability decreases more than the amount of DNA that is shared across the family. So for instance, if a patient is suffering from schizophrenia, the siblings of this patient have a risk of 10%. So it's less than the amount of DNA shared. So it means that there is an interaction between gene and environment for the pathophysiology of the disorders. And this is defining complex disorders. Complex disorders are always based on the same kind of genetic architecture. There is common variants with a low effect and rare variants with high effects. So common variants are variants that are shared by many people in the general population, and they have a few limited effects on the pathophysiology of the disorders, with a odds ratio around 1.05 or 1.1 or 1.2 at the maximum. So common variants with low effects, and at the other point of the spectrum, you have rare alleles causing Mendelian disease, or rare allele with a very huge effect. For instance, there is some alleles that confer a risk 20 or 40 or 50 times compared to the general population. And there is a range of variants. So if we focus just first on the common variants with low effect, which are called polymorphism, we can know them from GWAS. GWAS is an acronym for Genome-Wide Association Studies. So this is based on case control study. We have a number of cases, and we have the frequency of the allele in the population, in these population cases. For instance, the C allele is present on the top on 62% of the cases. Whereas in the control, the same allele, the C allele, is present in 49% in the controls. So we can compare the frequency of the allele, and we can derive a p-value of the association with the disease and an odds ratio of the association. And we can plot the results in a Manaten plot, which is called Manaten because it looks like approximately like a building in Manaten Island in New York. And you have for each chromosome a p-value of the association. So the higher the peak is, it means that the higher is the association with the phenotype. And we can now replicate this finding in several cohorts. We have a good replication score in polymorphism association with the disorders. And we can aggregate this score into a polygenic risk score, which is basically done by the formula on the right side of the slide. And we can derive polygenic risk scores per individual. The polygenic risk score is normally distributed in the population. So it means that for one individual, we can know exactly where the individual is compared to the whole group. So this is very interesting. But unfortunately, when we compare controls and cases, we can see that there is a big overlap in terms of polygenic risk scores. So we cannot totally split the controls and the cases population based on polygenic risk score due to this overlap. And this is very important because the effect size of the polygenic risk score is significantly associated with the disease, but very limited in terms of prediction. So in this context, the International Society of Psychiatric Genetics has published a genetic testing statement that is freely available online under this address. And they mentioned that research-based genome-wide association studies have found numerous common genetic variants reproducibly correlated with disorders at accepted levels of statistical significance. Individually, such common variants has very limited effect on risk, that is common variants with low effect, and there is no clinical significance for this common variants. However, when large numbers of these variants are considered in aggregate, known as polygenic risk scores or risk-island burden testing, the cumulative effect on risk is more substantial. But PRS informed by GWAS are currently considered research analysis and are not recommended for clinical use. This is very important to know that polygenic risk scores are very useful for clinical practice, but are not useful in clinical use. We do not recommend this kind of information be used in the clinics to identify high-risk individuals or help diagnose psychiatric patients, but this may change in the future as research advances. So polygenic risk scores cannot be used in clinical practice, but are promising in terms of research. If we focus on the other parts, so rare alleles with high effects for the disease, there is two different kinds of rare alleles. The first case is the copy number variation. What is a copy number variation? It's a duplication or a deletion of part of the chromosome. If you see on the left side of the slides, you have 4 different regions, A, B, C, D, and in some certain cases, you can have a deletion of a part of the chromosome. For instance, on the left, you have a deletion of the C part of the chromosome involving many genes, and this is known as a microdeletion, chromosomal microdeletion. On the right, you can see a duplication of the C region, which is called as a duplication. We can now explore all the chromosomes at the same time, all the region of the chromosome, and we can call the copy number variation from chromosomal macroarray. For that, we mixed the DNA of the patient and the DNA of control, known with not carrying any copy number variation, and we mixed this DNA after having labeled them by fluorescence. And what we can see here is that the normal allele, which is red, is known to have no deletion. So when the patient carrying a deletion, the color of the results will be red based on the normal allele. When you have a duplication, you have more DNA of the patient for this particular locus, and so the fluorescence will come from the patient DNA, so will be green. So that's a very easy way now to detect copy number variation in clinical practice. For the International Society of Psychiatric Genetics, this is of interest for clinical use because CNV confer high risk, but they are individually rare because they are rare variants with high effects. But taken together, they may contribute to a small but significant fraction of adult onset psychiatric disorders such as schizophrenia. And CNV could be very important for clinical implication for general medical care, but also to help patient and family to understand and accept the diagnosis, and could be very useful also for relatives. So CNV are very important for at least 3 diseases: intellectual deficiency, autism, schizophrenia. And this is, for instance, the result from the Psychiatric Genomic Consortium, showing with the same Manaten plot the association of copy number variation with schizophrenia. So we know exactly the copy number variations that are associated with schizophrenia, and we have a clear list now to be reported in clinic. Is it really frequent? We estimate that copy number variation in schizophrenia is concerning around 2.5% of the individuals. And based on this publication from Foley and al. In British Journal of Psychiatry last year, we can now know that developmental comorbidities increase the risk of carrying with CNV. So CNV is particularly interesting in schizophrenia, especially in those with developmental comorbidities like dyslexia, dyscalculia, or sometimes also specific school or ASD, intellectual disability, or epilepsy that are comorbid of schizophrenia. The second kind of rare variants are the single nucleotide variants, when you have a change in a nucleotide that will change the amino acid. For instance, on the left, you have a change of the C of a G to a T, changing the amino acid. So we can discover that by DNA sequencing, and that will be present in the next talk by Domenico Coviello from Italy. And we can sequence a panel of genes, a list of genes, or all the exons of the genome. So sequence all the genes, which is called like whole exome sequencing. And we can also sequence all the DNA, that is a whole genome sequencing. And the International Society of Psychiatry Genetics recommend the use of whole exome sequencing for intellectual disability or autism spectrum disorders. There is a consensus recommendation await publication, but this kind of exploration, whole exome sequencing, is increasingly used as a first-tier test for the evaluation of these two disorders. This is less clear for adult psychiatric disorders because we have less results coming from the research, but those things are going to change now. And pathogenic variants that disrupt some different genes that have been well known and described in the last years can be regarded as significant contributing risk factors in schizophrenia, even in the absence of comorbid developmental disorders. If we focus on autism spectrum disorders, there is a list of genes that are being recurrently associated as carrying a rare single nucleotide variant, and that if we find a variant in one of the genes in affected individuals, we can say that the causes has been discovered. One example on the left is the Fragile X syndrome, affecting around 1% of patients with autism spectrum disorders, and which is characterized by a repetition of CGG repeats in the genome. And the higher the repeats are, the higher the patient has the risk to be affected by autism, especially when you have a full mutation more than 200 repeats. We estimate that around 1/3 of cases of autism spectrum disorders can be explained by rare genetic variants. But things are going to change also in schizophrenia. And this is a Manaten plot showing that many genes have been now identified as carrying rare single nucleotide variants in schizophrenia. You have the list of the gene in red. So the question is, are common psychiatric disorders finally just an addition of rare disease? It could be interesting to test this hypothesis in clinical practice because it can help to fight stigma. For instance, in autism spectrum disorders, it can decrease the feeling of guilt, a feeling by the patient and the family. When we discover the rare variants, we say that this is not the education or the care given to the child that is in cause, but it is a real biological cause. The second point is that it could be very helpful for genetic counseling. For instance, in this example, the mother is affected, one child is affected, but what is the risk for the other child? What is the risk for the siblings? Or what is the risk for the children of the patient and his siblings? So this will be developed by Maria Soler in another talk from this symposium. The last point, so the third point is the question of the prevention of comorbidities. For instance, if you discovered a copy number affecting the region 20q11 causing schizophrenia, we could now explore other kind of comorbidities like change in calcium in the blood, or do an analysis and an assessment of cardiac defect, because this is frequent comorbid disorders in a patient carrying a deletion 20q11. The last point is the hope of developing personalized care for this patient. If you think that it's science fiction, it's not really true. Look at this review showing all the clinical trials developed in the last years for Fragile X syndrome. So if a child is affected by autism and you discover the Fragile X syndrome, which is around 1% of the cases, you can also propose to the patient and the family to participate to clinical trials. So that's really changing the treatment we are considering for autism spectrum disorders. The final hope is to try to develop preventive strategies in carriers. We know that, for instance, for 20q11 deletion, a large number of patients, around 40%, will develop schizophrenia during their life. So this is raising the hope of developing preventive strategy to prevent the onset of the disease in patients carrying this CNV. So we are entering into the era of precision medicine in psychiatry. We are blind for now of the genetic architecture of the patient or the genetic variants carrying by the patient. We are entering in the second part with the color. We are disentangling all this genotype and phenotype in psychiatry. And the last part is more hope now, but we are trying to develop treatment based on the genetic background of the patient. So this is really precision medicine in psychiatry, or personalized care in psychiatry based on genetic factors. So let me conclude by thanking everybody involved in the Engage network. Of course, you can find the list of the colleagues in the website of Sequence Action, Engage. And this is my affiliation in Paris, where we are trying to develop new care for patients carrying specific CNV or specific mutation. Thanks a lot.